Welcome to the Sniff Spotlight. Today we have the privilege of speaking with Katherine Katsoyannis. She is a medical director and owner of a private practice, and she works with many SNFs. So, Katherine, welcome.
Thank you. Thank you. It's nice to be here.
Yeah, so it's actually a real privilege to have a physician, someone with your expertise on the Sniff Spotlight. What made you want to come on?
I thought it would be an interesting experience. I actually had to confess that I didn't even know how to access podcasts. So now I'm learning a lot, and I always like to learn new things.
You have an MBA and you're a geriatrician?
Yes, correct.
How did that happen?
I'm the daughter of a physician. The plan probably was always for me to go to medical school, but I got a little sidetracked in college, I think. I thought about the long hours and the dedication, and in any event, I got my master's in business administration, and I got a job at a bank, and I soon figured out that I like people a lot, and I decided to go into medical school.
Wow, so that must have really helped you getting that MBA in the medical profession.
Well, it's helped me in the medical profession in the sense of now that I operate my own, it's a business, so in that sense. But it's also helped me a lot in my specialty of geriatrics in providing services to facilities along the lines of, I know what quality assurance is. I don't know if a lot of physicians do. I know regulations and compliance. I know how important recognizing the need to acknowledge and comply. There's a lot of different things you can do. You can do public policy, where business sense or business practices are very, very useful and come into play, especially now with the demographics, the aging population, how to manage that population effectively.
Yeah, so you purchased a private practice. What made you come to purchase a private practice?
Well, I went to medical school in New York City, and I married my husband, and I met in medical school. We got married, and so when I started having children, I decided, I wanted to come back and be around my family. I was recruited into the Advocate Medical Group as the first job. Again, maybe because of the MBA, I had a position of a little bit of authority there. I was the senior care line director. There was a lot of transitions going on, things between the hospital, Advocate, Lutheran General, the medical group. And I, in my capacity of as medical director at a facility, I had come to work with an older physician and really liked him a lot. And he was getting up there, and we started talking, and I thought, maybe it might be better if I just did, my own thing. So I purchased his practice. The deal was he was going to stay on for a year. He stayed on for like 12 years. So we had a lot of fun. My dad actually retired, and a couple months into his retirement, he called me and he said, "Can I come and see some patients?" And I'm like, "Sure, Dad." So yeah, we had our own little, I had my own little geriatric clinic going in the office, but I've not looked back. It's, the practice has grown and it's changed, but I really enjoy what I do, and,
So how has it evolved? You're currently servicing private patients within the private practice as well as skilled nursing facilities, assisted living facilities?
Correct. I used to do everything, as most independent practitioners, or what people think of, their doctor. I used to go to the hospital, do my rounds. I have office patients, I would see them. And then, because again, geriatrics, I would go into facilities. I had to give up the hospital. It's changing. It's just very difficult to do everything. So now I focused on the private practice, the community practice, and we have grown our group. I have 2 other physicians with me, and we have 7 nurse practitioners and a physician's assistant. So we do rounds at different facilities. We do scheduled rounds. I tell people, we're not doing this on our way to something or on our way from something. We dedicate that time to the facility. So I think we have really good communication with the nurses and families. They kind of know when we're going to be there. Yeah, that's how it's evolved. We're getting new opportunities all the time. Every day is different, which is great. And also being your own boss, it's a good work-life balance.
So you're 3 physicians now managing 8 skilled nursing facilities?
It's 6 skilled nursing facilities, but we've started going into a lot of assisted living facilities now. It's kind of interesting. Those facilities are still, they're considered like the people living there are in their homes. But in actuality, they're getting much, much sicker. And the goal is to try and keep them in place as much as possible. So bringing medical services to them, it's really great. I tell people, if you're going to make the effort to take somebody out, if you're going to make that effort, take them someplace fun like, the Botanic Garden. Don't take them to the doctor's office. It's not, right? If you're going to make that effort, make it a fun trip.
If I had you as a doctor, that might be fun.
Right.
You're coming into the assisted living. I know the pay structure, is the pay structure different when it comes to assisted living as opposed to skilled nursing?
It's all Medicare. The amount you get is different based on the site of service. So the office, the hospital, the facility, nursing facility, the assisted living. So that, but other than, it's not really the method, and it's just billed fee for service right now. That's pretty much how it's still working.
You mentioned that for the same patient, it matters where they are, where they're based. Like if the same patient could be in the hospital, a skilled nursing facility, assisted living facility. For the hospital, they'd be getting paid X, for the skilled Y, and the other one Z?
Right, for the visit. So if you make a visit to a patient in a hospital, you're going to be paid X. That same patient, if you see them at a skilled nursing facility, the scale is different.
So it's less usually?
Much less.
Much less. Yeah. So like a hospital, let's say, would be $500?
Yeah, we tell people that the business side of it, we took quite a hit when we gave up our hospital billing. Right.
But also going from skilled to assisted, you're also probably getting paid less.
Actually, because the assisted living, I'm not really sure how they came up with it, but I think we get a little bit more. And it is a little bit harder in assisted living than a skilled nursing facility in that the patients are more mobile and more likely to, you have to chase them around. You have to find out where they are, or, they do go out, so you've made a point of coming by to see them for some reason and they're not there. It's almost like doing a house call.
What's the reimbursement? Who's reimbursing you?
It's Med B. All of it's Med B, yeah.
Always. So it's not coming out of the skilled nursing facility's pocket as well. So they have nothing to lose by hiring a medical director.
And I'm sure every medical director get a stipend for services that are not direct patient care. I add value in that I have done the fellowship. I do know regulations. I do help with compliance issues. I help with surveys. I do in-services for the nurses. I support the clinical staff more broadly, not just on a one-patient basis. A change for me, having trained and had my first professional experiences in New York and coming here to Chicago, because in New York there actually were some real horrific abuses that occurred and spurned the reform of the Ombudsman Act in, I guess, was 60.
Tell me about the Ombudsman Act. I don't know.
Well, it's where the federal government laid down the law, so to speak. There were horrible things happening. Nursing homes were warehouses for old people. Basically, people were put in bed sores, falls. They were restrained mechanically and chemically, with medication. Just terrible abuses. So the federal government came in and they actually closed down a lot of facilities. They said the medical care was just abysmal. So in fact, in New York, the nursing homes had closed staff. They credentialed their staff, much as a hospital does. So they were doing that actually at nursing homes, closing facilities. It really changed the industry. They had responsibilities. They had to attend to the patient. The other thing about the Ombudsman Act was up until I think that Medicare would only pay a physician, that Part B, but they would only pay a physician to see a nursing home patient once a month, no matter what. So physicians were seeing their patients once a month in a facility, but if they got a call about anything else, they would just say, send the patient to the hospital. I'm not going to come in there. So as a result, there were a lot of unnecessary hospitalizations. All that happened out of that was good. A lot of facilities will assign a patient to a doctor. Sometimes that is not necessarily based on the quality of the care. There might be other issues. And even I in my group, we go to so many different facilities, but there are even some of my patients, if they're going to have rehab, they're going to have surgery, they're going to have rehab, they want to go to a facility that's closer to their daughter. Completely understandable. I always tell them, unfortunately, I'm not going to be able to come because I won't be able to give you the attention that you need. My advice is ask the nurses who they would want to take care of them. Don't just accept assignment.
So your primary clients, you have 3 physicians dealing with 6 skilled nursing facilities and some assisted living facilities. Did you guys max out, or are you able to grow?
We're able
see
to
more
grow.
patients?
We're able to grow. We still have some, it's kind of a fine line. Again, the business part of it, like growing, but still being able to provide the services that, I expect. Like, we want to have a quality product, and it's a customer-based service, and our customers, not just the patient, it's the family, it's the facility, it's the nurses in the facility. So it's kind of a fine line of growing, but not saying, not promising something that you can't deliver. We do have capacity, and I've recently been hiring some other nurse practitioners to kind of help out with that too. So it's exciting. So we are also a part of the post-acute network that Advocate has. So we have, for the rehab patients, they're pretty high acuity. I mean, they're just out of the hospital. Post-acute network wants us to see the attending physician to see the patient at least once a week, and the nurse practitioner or the PA to see them twice a week. So it's 3 visits a week. We're measured on outcomes. So return to hospital is a huge one. We want to keep those patients out of the hospital. We have to see them. We have to monitor them. We have to check their vital signs. We have to check labs. We have to provide services that traditionally weren't provided in nursing homes. In intravenous medications, intravenous fluids even. It depends on that. We have a couple of our facilities that are very active. They get 10 to 20 admissions a week. They're being rehabbed, and
you need to see them.
We need to see them, make sure. I mean, everything, if it's rehab, we have to make sure that they are in good shape so they can, do their rehab. So we have to manage pain or whatever it is. And medically complex patients now are more lucrative for the facilities, and so they're admitting patients with tracheostomies and prolonged courses of antibiotic therapies and things that require more frequent monitoring.
Right. So you're both looking at patients that are coming in and monitoring them, but you're also looking at the overall picture, helping like with the MDS coordinator, rehab director.
Where I am medical director, that my schedule allows me and the facility to set up. Usually we'll have at least 1 meeting a week, and that might be, 1 week might be the QA meeting, other week might be, if we have a problem we want to look at, so return to hospital. So we look at every patient that was sent to the hospital. Why? What happened? Who was the doctor? Who was the nurse? What were the circumstances? Things like that, so that we can address any issues, any trends we see. And then we also have the custodial patients, the long-term care patients, and those patients are not acute, or they might get a cold or whatever, but generally speaking they reside in the facility, and they are usually seen once a month because their medications need to be reviewed once a month and signed off on, and it's a good practice. I mean, they're not, The assisted living patients, we actually try and put them on a schedule. Some of them are in very good shape, and only the squeaky wheel gets the oil. We try and not do that. We try and make a schedule so that even somebody who's in good shape, an older person requiring services like that, once a quarter, once every 3 months, we put them on a schedule so that we don't want to forget anybody or let things fall through the cracks.
Do you want to tell me about some of the facilities you work with?
I was speaking earlier with Andrew about one of the things I come across and seen is the ethnic-based facilities. My father was very involved, spent 20 years of his life to establish the Greek American Nursing Home. And because he had a lot of Greek patients, obviously, and recognized that, they didn't have a place where they felt comfortable at a time when they needed more support. So that's a great building and a great experience.
Oh, so you're working with Dino Varnavos?
Yes.
He's a nice
Dino's
guy.
a good friend of mine. Yeah.
Oh,
Yep.
cool.
Yeah, absolutely. And Dino's done great there.
Yeah, we got to get him on the Sniff Spotlight.
Oh, absolutely.
Shoot him out. Tell him how amazing this is.
I will, absolutely. I was telling Andrew, too, that one of the trends, I think, we're going to see how this works, but where they're setting up smaller, like actual homes. So the group home concept that they do for kids now, they're thinking about trying to do it on a larger scale for older people. It's a community.
Yeah, it's popping up a lot in Indiana from what I see.
Yes, yeah. And actually studies have shown that they have less health complications and they're just generally more, satisfied with their lives, happier, which probably is why they have less health complications. So I kind of see how to do that. So providing services, going out and providing those services, wherever that person is, as opposed to bringing them into, big institution or something like that.
Yeah, that's getting more popular.
Yeah.
You were amazing.
Oh, really? Good.
You're so amazing.
Oh, thank you.